Thank you, Brad. And now it's my privilege to introduce Dr. Alex Golby, a colleague of ours, a neurosurgeon at Brigham and Women's Hospital. She heads the image-guided therapy program there. She's a co-director of the Amigo system, the multimodal MR PET angiography suite. And, she's somebody else who I sort of grew up with. She started about the same time I did. She came over from Stanford. I think she did some work with John Gabrielli while she was there. And I think fMRI has been really important for her work as a neurosurgeon for some of the reasons that I discussed previously. And it looks like she comes injured. So we'll take our time and welcome Alex.
Good afternoon. So when I was a kid, there was a commercial on TV where they cracked an egg and they said, "This is your brain." And then they put the egg in the frying pan and they said, "This is your brain on drugs." That was sort of fMRI 1980 or 78 or something. So I am on drugs because I blew my knee out last week and had surgery to reconstruct it. So if I say something really stupid, it's not really me. It's the drugs speaking. And I have lots of friends here, so you guys will, be apologists for me. So as Steve said, I am a neurosurgeon. I trained at Stanford, and while I was doing this brutal 7-year residency, I was incredibly lucky to meet John Gabrielli, who's in the back there. And I went over to the psychology building, which was a short walk from the medical school, and I said, "I would really like to do my research years with you." And luckily, he had I think, some good interactions with Marty Morell, among other people. And so he said, "Sure, come on over." And then I was lucky enough to meet Gary Glover. I said to Gary, "This is what I want to do. I want to look at memory encoding in patients with epilepsy to see if we can lateralize memory. Can I do that, kind of like tomorrow?" And he said, "Sure. Basically, tell us what you want to do." So I, similar to what Steve told you, I learned how to pitch an idea, and over the course of about 2.5 years working with those folks, learned a little bit about how to start investigating those ideas using fMRI. And then I was lucky enough to meet Peter Black, who was the chairman of neurosurgery at the Brigham. And this is actually a point in my life when I thought I might not be a neurosurgeon, because I was really loving the science that I was doing. And I had lunch with him because he was our visiting professor, and I said, "Well, I'm not sure neurosurgery has room for somebody like me." And he said, "Oh, no, that's not at all the case. We need more researchers, so please come and be at the Brigham." So I came to the Brigham, and I met lots of folks here as I started to tour around and went over to the Martino Center and meet folks and try to sort of carve out a little niche for myself. I can't say that without mentioning Frank Yolez and Ron Kikinis, who were my supporters locally at the Brigham. So I started to do my clinical work as a neurosurgeon. I was blessed with a robust clinical practice because of Peter Black's reputation. And I started doing fMRI on our patients, and I'm going to tell you a little bit about what we did. So we are trying to advance the slide. Maybe this is not how it's done. Any idea how to advance the slide? Okay. Yeah, okay. It's not brain surgery. So the promise of fMRI for neurosurgical planning is very exciting, right? Because as neurosurgeons, especially when we're talking about operating in the brain, you're trying to figure out what is what. And the reality is you open the head and it all looks the same. And our ability to do successful intracranial neurosurgery is completely hinged on our ability to see what it is we need to see. And that has been many techniques. It's been first angiography and CT and the advent of cross-sectional imaging and structural MRI. But really, this ability to see function was an absolutely unprecedented look. You know, this look behind the curtain, this look into the cranium before you did a surgery. And so when I saw this, I thought, this is just unbelievably cool. I want to be part of this. And this is what we can do in a very straightforward manner now. This is a patient of mine, maybe a decade or so ago, who had a low-grade tumor. He presented with a motor seizure. It was obvious structurally that this was in the motor cortex. And this is the mapping we do. And we can map, you see on the right side images, the hand area and the supplementary motor area, and in the left image, the foot area. And we can really know, before we go in there, exactly where this person's motor area is going to be. And that is a game changer in terms of planning our surgery. So that was our promise, that was our goal. There were many steps along the way to get there. And there were some early studies, and some of those actually came out of John Gabrielli's lab. And I wanted to point this one out because John Desmond, working with Marty Morell, looked at epilepsy patients and wanted to try to lateralize language. And you've heard a little bit about this from Steve, so I won't dwell, except to say that what was really different here was not group analysis, not trying to make statistical inferences about where function was located or how functional anatomy might differ in groups, but to look on a single subject basis. And so what John did is he looked at patients who were left dominant for language and right dominant for language. So on a single subject basis, he found correlations, and rather than looking across a whole group. And that's a major theme, because as a surgeon treating patients with brain tumors, I don't really need to know anything about the brain in general, but I need to know as much as possible about that patient's brain in particular. And I almost know a priori that that patient's brain is going to be funky in some way or another. And so that's really one of the big steps that we had to do, was to really hone down on this question of how do you get single subject data. And interestingly, I think that's coming around back to the neuroscience, and we'll talk a little bit about that, and you've already heard a little bit about that. So we routinely map, as Steve told you, these functions. We can make these beautiful pictures. This is actually a bilingual patient, English and Portuguese. We could map both languages prior to operating this large low-grade glioma. And you can imagine how helpful that would be. And specifically, it can help us do a few things. It can help us select an operative strategy. Are we going to do a biopsy? Are we going to do a resection? What corridor are we going to take? Where might we decide the riskiest portions are? Where might we be more aggressive? Where might we be more conservative? Do we want to use intraoperative mapping, which is the awake mapping you saw, where the patient their brain is directly stimulated? It's immensely helpful for those patients who can't or won't do awake surgery. It helps us do smaller openings and do much more focused mapping when we do the mapping. And it provides a fallback if that mapping fails. And I can tell you in my practice, I do much less awake surgery now than I did when I started 15 years ago. So, and then just to make the point, this is life-altering for our patients. If you leave the OR with a permanent neurologic deficit, your life will never be the same. I left the OR last week with my knee hurting like hell, and my life has sucked, but I know it's temporary. For these people, it's forever. If you cause a neurologic deficit, their life is irreparably altered. And not only that, but for the tumor patients, they actually live less long. probably because it's so hard for them to just do functions of daily life. It's harder for them to tolerate things like yet another course of chemotherapy or radiation. So preserving that function is critical, and so we have to try to do a resection that spares that while being maximally complete in terms of removing the tumor. So this can be used to increase the confidence of the surgeon. This is another patient of mine. If you showed this mass to somebody without the fMRI, they would say, oh my God, that's bad. That's in a bad place. But with the fMRI, we really can confidently tackle this, and this patient did great, and he was fine after surgery. He's neurologically normal. It can also sometimes decrease confidence. This is a patient actually who had right lateralized language, unsuspected, and you can see across tasks the sort of congruence of that, and that led to kind of a change in our strategy, among other things, not just because of that one activation, but because of the implication that the entire language network is there, including the white matter tracks. And then we can also see reorganization over time. This has been used in some cases to actually allow a more extensive resection at a later surgery as patients gradually reorganize function. I've also spent a lot of time bringing all this into the OR because in the end, that's how we work, is we need to be able to kind of bring this data, and it's a lot of data. So when I started, I literally had spent some money, of which I did not have very much, on a color printer, because this was so I could print out the maps and tape them up on the wall in the OR. And that was great, but now we can do much more, and this is really thanks to the folks in the National Center for Image-Guided Therapy and Slicer, and the ability to take these maps and bring them into the operative field. So this is an example of a patient with a small lesion, but right in the motor cortex. This is integrated with a navigation system. For those of you who haven't seen it, navigation is like GPS for the head, so that when I'm opening the head, I know exactly where to make the craniotomy. I can see exactly how the correlation between the location of the lesion on the image and where it is when I'm staring at the surface of the brain, trying to decide where to make an entry point, and also how extensive to make the resection. And as an example, this is the view through the microscope. This is, not sure if I can do this, but this is the bony opening here, and this is the scalp here, and this is the area of the tumor, which is outlined because of basically the integration of the structural imaging into the microscope, and then these are the outlines of the functional areas. And you can, I think, appreciate that this all looks awfully similar, and that it's very difficult to know what is what when you're in there deciding whether to take out another couple millimeters or not. So this is the kind of guide that we are now able to do pretty readily. It's also very useful in situations where the brain mapping fails for one reason or another. And this is challenging. It's challenging for the anesthetist, it's challenging for the surgeon, it's challenging for the patient. And in our hands, about 20 to 30% of patients fail. They get confused, they get tired, their airway doesn't cooperate because they're sleepy, they have a seizure. And on the left are some examples of patients with lesions really in obviously scary areas. And just the ability to have this as a backup has been incredibly helpful. It is not unheard of for patients to open somebody up and back out. And to me, that's like the worst possible thing you can do to somebody, psychologically and physically. So the ability to have sort of a salvage situation, I think, is really critical. Another example, which is just to support this kind of general idea that we had, is that as our technology for doing the intervention improves and changes and becomes less invasive, we are actually going to completely have to not do this open mapping procedure where we expose the cortex and map the cortex, map the subcortical white matter, because we're not going to open the head, or at least not very much. And so this is an example. I don't actually have any fMRI on these pictures, but it the trajectory was planned, taking into account fMRI and DTI. So this is a patient who had a recurrent brain metastasis just under the motor cortex. And what we were able to do was, using MR guidance, get in it. We were able to drain the cystic portion of it. Then we were able to biopsy it, because the question was how much is tumor recurrence versus necrosis. And then we were actually able to laser it. So we ablated it with a laser. And then you can see this sort of ring that is created from the blood-brain barrier breakdown at the edge of the ablation. And then even after that, we were able to demonstrate the integrity of the corticospinal tract. And so this is pretty awesome, really. I mean, the patient went home the next day. His lesion was treated. He had metastatic cancer. So we were able to do something that took him out of his, few remaining months, but made him much better. And I would envision that, there will be many more of these things. One of the maybe you can help me, Gary, very active areas at the Brigham is in focused ultrasound, which is totally non-invasive way of treating brain tumors or potentially other conditions where the cranium is not opened at all. It can be used for ablation, it can be used for neuromodulation, it can be used for drug delivery, and for all of these things, the ability to work from a map. So I always make the analogy, if you're going on a trip, it's nice to have a map, and that's very true of brain surgery. So let me see where we are. Here, yeah, okay. So I don't know why that happened. So I'm just going to go quickly just to say there's pretty good data now that fMRI helps. It helps patients have greater extent of resection. It helps them have fewer neurologic deficits. There's still a lot of debate among my colleagues. Is it worth doing because we're just going to do electrophysiologic mapping anyway? I think there is at least some data that supports the fact that in some cases we are more accurate than electrophysiologic data, because a patient in the OR under anesthesia has a lot of things going on, and it's not going to necessarily be the easiest thing to see changes until they're too far. And this is an example of a study in which over half the patients had unanticipated language deficits when done awake. So I think that there obviously is a lot to work on. We all want to make our patients have the best outcomes. I'm not arguing that fMRI and electrocortical stimulation are antagonists, but simply that they have to be used and deployed in intelligent ways and appropriate ways for each patient. This is another example versus the WADA test, which simply suggests that in many cases where there is a discordance between fMRI and WADA, it's actually the fMRI that is more predictive of clinical outcome. This is just to show the evolution of this. So as I said, I came in 2001 as the chief resident. I started really doing this in 2003. And these are the numbers of these are the numbers of patients fMRI pre-surgical mapping studies done. Where the bars turn pink is when we began to have a clinical service, i.e. bill for it. This was put together with Srini Mukundan, who is the new chief of neuroradiology at the Brigham. And you can see a huge number of studies that we now do. And we've had, I think this may be the largest clinical series anywhere. We have over 1,000 patients that we've studied with fMRI. 850 of which were done clinically with formal reads by a neuroradiologist and my colleagues, largely Srini, Ray Huang, and Jeff Young. And also, I thought this was really interesting, which is fMRI as a proportion of craniotomies. So this is all supratentorial craniotomies. It includes things other than brain tumors. But you can see in this year's, I guess this is 2014, slightly old data, but nearly half of the craniotomies are being mapped. This is being driven by my colleagues, not by me. So now I'm going to speak quickly about disadvantages of fMRI. And I'm not going to go into this too much because you've had a whole day of this, except to kind of highlight two things for patients. One is that it is dependent on task performance. So if you're going to do a language study, they need to be able to perform the language task or the motor task, whatever it is. And the other is that there are no widely accepted standards, and this has made adoption kind of difficult. So I'm going to show a couple things. You've seen some of this before, but this is work led by Yanmei T in my lab. This is based on work by Hassan et al., which showed that there were correlations across different subjects in their brains when they were viewing the same movie, in this case, The Good, the Bad, and the Ugly. And the question was, could we adopt this to map individual subjects? Because again, everything we do has to come back to the individual patient. And so we used a more mellow movie. This is The Parent Trap. And we showed this to the patient, we showed this to healthy subjects, and we looked for areas that were correlated across time, across subjects, and actually nicely we see some of the language areas are correlated across subjects. Are these selective to language content? So Yanmei made ROIs and looked at the temporal correlation. These are some time plots that you can see across the full scan. So the scan is something like a 7-minute section of the movie. And you can see that during these dialogue sections, the signal goes up, and then during the sort of interim long shots without dialogue, the signal in these areas goes down. And she's then applied this to some of our patients. This is an epilepsy patient who had implantation, so that allows us to, again, get the gold standard confirmation. You can see where the electrodes were placed, and you can see the results we get using this resting state approach. And, well, I'm sorry, what I just showed you was a movie watching approach, but we've also done a resting state approach. All of these are based on the kind of connectivity analyses that you just saw presented. The beauty of this would be, if we can make it work routinely, that patients wouldn't have to do language tasks. So there are a lot of patients who are mildly aphasic. They do okay when you talk to them in the clinic, but when you put them in a scanner and say, generate an antonym every 2 minutes, they can't do it. And our hope is to come up with tasks which are easier for them to perform, like watching a movie or just resting, that would give us reliable single subject information. We've also approached some of these questions together with Polina Goland and her group. This work was led by Jorg Langs. To try to decouple structure and function. So one of the banes of my existence is that every brain tumor patient's brain is different, and they have a lesion in a different place of a different size, causing a different amount of mass effect with different amounts of edema. And so we can't always find which are the activations of interest based on where they are anatomically. And so Jorg's and Polina's effort was to try to find the areas of interest by how they were connected and what their temporal correlations were. And then along the same lines, work in my lab done with Lauren O'Donnell and many of her colleagues, C.F. Weston, has been to try to integrate the information we get from tractography with the information that we get from fMRI and also the cortical sulcation patterns. So again, as a surgeon, I need to preserve the whole thing, not just the cortex, but the cortex and the associated white matter tracts that are subserving the important function. Examples here from patients with corticospinal and arcuate fasciculus outlined. And really, our goal is to try to enable a sort of semi-automated look at these individual subjects' maps, again, so that this could be done in settings outside of the Brigham or the MGH, sort of more readily deployed in different lower resource settings. So the idea is to try to use machine learning and large-scale features to create atlases that then are somewhat robust to the variances that we see in individual patients. So this work uses this approach to create clusters of white matter tracts and parcellation, and then to try to see if we can still do that in the face of reorganization and displacement. So this is not an easy problem. This is not one that I would claim that we have solved, but one that we are working on. So this is an example of applying that algorithm to a patient, and you can see the purple area was not in the original parcellation, and that's where the tumor is, and we think that that's really the insula, what would have been sort of the insula kind of being seen on the surface with some reorganization. And this is an example of using this approach and then using individual subject fMRI as a kind of validation to see whether our predictions correlate with what the fMRI predicts are the language areas. So again, not a solved problem, especially language is a tough nut to crack, motor's much easier, but really interesting approaches using very sophisticated computational approaches and increasingly detailed acquisitions across different modalities. So with that, I will conclude with a few points which I think are take-home. Of course, first and foremost, understanding the individual's functional anatomy is critical. And I'm increasingly also enthused at seeing neuroscience efforts to drill down to the individual differences and not look exclusively across groups. And I forgot to mention work with Nancy Kanwisher and Ev Fedorenko, and they're doing a lot of that, and as are many people. Developing methods suited to patients is really important, and also methods that can be implemented in relatively lower resource settings with technologists who may not be as skilled as the people we're used to working with. Investigating variability, including reorganization, is a huge area that we continue to look at, and integration with other modalities. And then I would like to thank you. I made the font small here because there are a lot of people who have helped me, inspired me, collaborated with our group, and of course our funders as well. So thank you very much.